everyone, I am Manali Reshamwala, Assistant Professor from LG Institute of Physiotherapy. Today I am going to talk about Cardiac Resuscitation Part 3. It is a part of syllabus for final year physiotherapy students of Gujarat University and the subject is Physiotherapy in Cardiopulmonary Conditions. In previous lectures, we have discussed about cardiac arrest, introduction of cardiac resuscitation, and basic life support in detail. Once a patient gets emergency service and we can make the patient to reach up to hospital, we can start with the advanced life support. Advanced life support will include DEF, that is drugs, ECG and fibrillation treatment. Where first we'll start with drugs, where we need to give drugs to the patient to make heart normal sinus rhythm. Cardiac compression and ventilation of the lung should not be interrupted meanwhile. And we need to also insert a central or peripheral intravenous catheter or needle so that we can provide intravenous drugs. If patient is already in hospital, we may find central or peripheral venous catheter inside the patient already. Then we have to make sure whether the patient is intubated or not. If not, then we should intubate the trachea. By using endotracheal tube, we can provide artificial ventilation also, as well as we can maintain the airway pattern so that patient, and as well as any kind of vomiting or any kind of fluid does not get into the lungs, so that we can prevent lung contamination. Next thing, this is the drugs we can use in emergency situation, where first is adrenaline 0.5 to 1 milligram repeated every 3 to 5 minutes as necessary, and second is sodium bicarbonate, which is given 1 milli equivalent per kg body weight. This is repeated every 10 minutes of arrest time. For adult and children, there are different amount of solutions to be given, so that should be taken into consideration. If somehow intravenous access is not being established, drug can directly given into the endotracheal tube to the patient, so it will work through lungs. Or suppose that also does not happen, then at last resort we can directly inject adrenaline into the heart through chest wall. Though that may create damage to the heart muscle, there may be chances of pneumothorax or cardiac tamponade, but still we can survive someone's life. Next is E, that is ECG. We need to monitor the patient so that we can get to know the exact condition of heart or whatever the electrical activity of the heart is going on. So by that way we can get to know the condition of heart and we can give proper medical treatment. So if we find in ECG that there is ventricular fibrillation, then it should be treated by defibrillation. If we find there is asystole, then it should be treated with adrenaline first and then defibrillator. In case of ventricular tachycardia, it may be treated by defibrillation or varapamil, and bradycardia may be treated with atropine. Next is F, that is fibrillation treatment. Defibrillator, we need to give defibrillator to patient when we get on ECG either coarse ventricular fibrillation or ventricular tachycardia. At that time we can ask everyone to clear the area and we can give defibrillator to the patient. Meanwhile, cardiac massage and artificial ventilation should not be interrupted for more than 30 seconds. After connecting defibrillator to the power supply and switching on, it should be charged to give 200 joules or roughly 3 joule per kg body weight of the patient. The electrode should be well lubricated with conducting jelly so that current can be passed through resistance of skin. And the placement of electrode will be like one electrode should be placed at the below the right clavicle and another at the apex of the heart. once we place the electrode, we should check whether the area is clean or not. No one should be touching a patient, or no one should be touching even the bed of the patient. Then we need to apply firm pressure on the electrodes and apply press the defibrillator button, which will give current to the patient. And we need to wait for 5 seconds to see the result in ECG. And if we find a normal result, then it's okay. Otherwise, we need to continue with cardiac massage and artificial ventilation as necessary. As I said earlier, it should not be interrupted for more than 30 seconds to giving defibrillation. Here is a figure which is showing the placement of electrodes of a DC defibrillator. Next is so let's summarize the use of defibrillator again with the drugs. That first we need to externally give defibrillation using whatever the range, 100 to 400 joule is the range, and repeat the shock is necessary. We can convert the fine fibrillation to coarse fibrillation using adrenaline, and then we can give defibrillator, and followed by it lignocaine 1 to 2 milligram per kg intravenously is necessary. If defibrillator is not if is not available somehow, then we can give lignocaine only, which will help to convert rhythm gradually to the normal sinus rhythm. After that, prolonged life support. Now we need to judge. G means judging. We need to judge the likely outcome of the resuscitation. Whatever the time we have given, and whatever the things we have applied, whether drug or massage or ventilation, everything, we need to see or judge how much amount of problem has been recovered. Then judge the cause of cardiorespiratory arrest and treat it. If we find that patient is now stable, then that is not the end. We need to find out first what was the cause of that cardiac arrest, and we need to treat it first, so that again we may not come across with such attack. Next, H is human mentation, where we need to maintain patient's cerebral flow and oxygenation to brain to preserve cerebral function. If brain is working properly, we can maintain patients alive. So for that, we require to give mechanical ventilation as well as oxygenation through mechanical ventilation to maintain oxygenation to brain. Next thing, we need to reduce and control intracranial pressure. Intracranial pressure can be measured using device inserted directly into the brain, as well as we can provide mechanical ventilation to the patient, which is most effective way to reduce and maintain the stable patient's intracranial pressure. If there is swelling or bleeding in the brain, we can give steroids and diuretics to reduce swelling. Next is monitoring of the cerebral function. If everything is working properly, we need to monitor the cerebral function in any kind of things or any kind of change should be noted and treated as early as possible. We can monitor it through cerebral functional monitors or electroencephalograms, as well as with repeated neurological examination by doctors, physiotherapists and nurses, so that any kind of changes can be observed very quickly and we can implement treatment very easily. Last is I, that is intensive care. We need to provide intensive therapy to the patient. We need to provide intensive nursing to the patient as well as intensive monitoring to the patient. Why this monitoring is required? Because once a patient who have undergone for CPR, that is cardiopulmonary resuscitation, the care need to be taken that it may again develop, patient may again fall for need of CPR, and that can be observed through monitoring only. So if they have any kind of further cardiac or respiratory arrest from the same cause or original insult or as a result of consequences, we need to monitor it. These kind of patient may require support of both cardiac and respiratory to maintain adequate tissue oxygenation. Cardiac support may be pharmacological as well as mechanical. Pharmacological cardiac support can be with the drugs dopamine to increase cardiac output or vasodilators such as sodium nitroprusside to reduce the work done by the heart, as peripheral resistance is reduced and work done by heart is also reduced. If heart is not being working in patient properly, we can also give a mechanical support by intra-aortic balloon pump machine IABP therapy, which is working as an external pump to maintain circulation in the body. Next is respiratory support. This also can be pharmacological as well as mechanical. Pharmacological support can be respiratory stimulants such as doxapam, or in a case of narcotic overdose by narcotic antagonist naloxone. The mechanical support is artificial ventilation provided to the patient until patient's respiratory mechanism works properly. Other problems should also be treated along with cardiorespiratory conditions like one of the most common problem encountered in these patients is acute renal failure. But with careful management and careful monitoring, we can prevent it by keeping monitoring on fluid input and urine output as well as electrolytes and osmolality. Everything we can maintain or prevent acute renal failure. Here is the reference. Thank you.